So tonight we're very privileged to have Dr. Storch present to us on the new COVID variant. And to formally introduce him is Rabbi Menachem Greenblatt, who's the Rav of the Aguda in St. Louis. And Rabbi Greenblatt doesn't know this, but I saw Rabbi Greenblatt was one of the rabbis that came out very strongly against families coming to St. Louis and spreading COVID. I think it was last Pesach, Rabbi Greenblatt, that I saw your literature. And, you know, a lot of the rabbis have been very strict on COVID, and Rabbi Greenblatt has been one of the leaders. So it's really great to have him introduce Dr. Storch tonight. And on a personal level, Rabbi Greenblatt's father, Rabbi Ephraim Greenblatt, and his mother, Rabbi Miriam Greenblatt of Shalom, they were very impactful in the entire community in Memphis. So any of our members, Jack Bells, Ira Littman, Oliver Shalom, and my grandparents, they had a tremendous effect on all of their spirituality. So I want to thank Rabbi Greenblatt for all of his great work and for his legacy from his wonderful parents. And with no further ado, Rabbi Greenblatt.
Thank you very much. It's a pleasure to be here. And I just also wanted to begin by acknowledging Jacob Gold and our relationship, a relationship of the Gold and Greenblatt families and the Rosenberg families that we go back 7 decades, that long ago. I'll let you all in on a little secret. I remember when Jacob was born, more specifically, I was at your parents' wedding. So we do go back a ways. And I know as the shul rabbi, I just know how much a president of a shul needs to be involved with. I know this firsthand, so how skillful and diplomatic and devoted you must be. And from afar, I do admire you, and I know that you're undertaking some big things with the renovation of your shul, I'm just told, so I'm sure that it's in able hands. And again, I'm very proud of you and all of your accomplishments, and thank you very much for thinking of me to be part of this program. When Rachel called to invite me to introduce Dr. Storch, her father, I readily agreed, although typically my knee-jerk reaction when I'm asked to participate in things is to demur and not to accept it readily. But when it comes to Dr. Storch, for sure, I wanted to be here and just to be able to express my personal hakaras hatov, my gratitude and the collective gratitude of our entire community for everything Dr. Storch has done for us over this past almost year and a half. When COVID broke back in March of 2020, the rabbinic leadership of St. Louis, of our Jewish community, were faced with a challenge, the likes of which we never could have anticipated or expected. We immediately convened a meeting of all the pulpit rabbis and the leading experts in the fields of infectious disease. And it became apparent very quickly from the start that we were blessed here in St. Louis to have a nationally recognized figure among our own constituents and to guide us along this process. His brilliance, his insight, his clear direction to our shuls and our schools proved to be invaluable, to say the least. We could not have done it without him. Dr. Storch's superb medical knowledge and his sagacity is surpassed only by his humility and his devotion to his fellow Jew. What a humble person, and someone who just, you feel like he's a friend, even though he has this a towering background of knowledge and expertise. I'm not here to read his credentials that you have on your emails, but that you could do yourself. But I just wanted to add something in his credentials and list of accomplishments that does not appear in the bio. Rachel, I would imagine that you're the one that's responsible for writing that bio, but let me tell you what you didn't put down. The Torah thought. The Torah uses the language v'rapo yirapeh in context of a certain aspect of damages. If one Jew injures another, he must pay his doctor bills. But the sages of the Talmud scrutinized the double language v'rapo yirapeh, and from here the Talmud teaches us, mikan, from here we know that a doctor is given permission to practice. In other words, the Torah, our holy Torah, conveys the license onto a physician to be able to practice medicine, something that he would not have been able to do had the Torah not sanctioned it. And so we view the practice of medicine as a holy calling. In fact, we know in our Shemona Esrei we say Rofeicha Basarif, in our davening, our brachos, Hashem is the ultimate healer, but Hashem does have many shluchim, many emissaries that, if you will, partner with him. And Dr. Gregory Storch is that type of physician who understands that with all of the credentials and all of his experience, but he feels the calling is from Hashem, and the Torah's license, which he very, very proudly displays, and not only the way that he gives, not only in the direction that he gives, but it's in his bedside manner. Usually we refer to bedside manner is the manner in which a doctor treats his patients when he's visiting with them. But I have to say that when you are very nervous and you're fearful and you don't have direction and you call a doctor, they could just simply be very terse and tell you what you need to know, or they could be empathetic. And that is the bedside manner with which Dr. Storch has dealt with all of us here in the community. We were like a ship without a rudder. And Dr. Storch really navigated us through this with his humility and with his wonderful personality, and of course with his expertise. So just on a personal account, our shul would not have had the ability to conduct high holiday services last year. The space in our synagogue was not possible to accommodate our crowds. We had to rent the gymnasium of a public school, and we called Dr. Storch. He came down, he took his time from whatever he was doing. He met with us several times. He gave us hours of his time and just telling us what we need to do, measuring the social distancing, the washrooms, the sanitizing facilities, just whatever it took. And we felt that we were good hands, and we had that sense of security, and we were able to accommodate the crowd that we have on Rosh Hashanah and Yom Kippur. I can't begin to fathom how many phone calls and emails Dr. Storch has responded to over this past year and a half. I really can't even imagine. It's in the thousands. And I know that many times he has to repeat himself, and we would tend to say, oh, here we go again. But that's never the feeling you get when you speak with Dr. Storch. And so there's just nothing I could say to really convey the gratitude that we have to have someone of his caliber in our community to guide us along. The only thing I will say, as much as I am in awe of Dr. Storch, but I don't know if he has the ability to pull a rabbit out of his hat. And this is what I mean. I don't know who titled this symposium, but it's called Update on COVID-19. How scared should we be about variants? Now, that title kind of presupposes the fact that we are scared. The question is just how scared we have to be. Dr. Storch, maybe with your presentation, I don't know, but could we rename this presentation, Should We Be Scared of Variants? And to lower the scare factor here. But I'm sure that we're going to hear everything that we need to hear to keep ourselves safe and protected. And again, I thank all of you, Jacob, Rachel, and certainly Dr. Storch, for this evening, and I'm eagerly looking forward to stop talking and to listen to what Dr. Storch has to say. So thank you very much again for inviting me to be part of this wonderful evening. Thank you.
Thank you, Rabbi. Thank you so much.
You're welcome.
Okay, Rabbi, thank you just very much for that incredible introduction. And I almost feel like I can't give the talk now because I can't possibly live up to it, but we'll try. And let me go ahead and get started. Very happy to be here talking to Fifth Avenue Synagogue and Jacob and my many other friends there, and not to mention my daughter, Rachel. So here is an overview of the COVID pandemic in the United States to date. And what you can see are 4 peaks. We're in our 4th peak right now. It's a peak that I think most of us didn't think was going to happen, but here we are in the middle of it. Related to a variant. On the bottom, we have some numbers, some statistics of numbers of cases. We've had more than 36 million cases of COVID in the United States to date, more than 600,000 deaths, which is really a hard number to really fathom. In Israel, there have been 934,000 cases, more than 6,000 deaths. In the world, more than 200 million cases and more than 4 million deaths. So we're living in the middle of a truly historic event that people will be talking about for decades and possibly centuries. We really are in the middle of an unusual phase of this epidemic, and this is this fourth cycle that is related to the Delta variant that we're going to talk about, and it is making its way to New York City. There is an increase in cases in New York City going on right now. I took these figures from the New York Times. There have been more than 1 million cases to date in New York City, more than 33,000 deaths. But what's of great concern is the daily case count now is nearly 2,000, and that represents a 63% increase over 14 days earlier. Now, the virus that is causing all of this trouble is called SARS-CoV-2, CoV for coronavirus, and that's a cartoon depiction of the virus. It's an RNA type of virus, and there are many different coronaviruses in nature. They're very common in animals, and there are 4 mild coronaviruses that occur in humans, so-called seasonal coronaviruses. And now there have been 3 epidemic coronaviruses. There was the original SARS outbreak in 2002, 2003, and there was the outbreak of MERS in the Middle East, which is actually still going on, but hasn't spread the way COVID has. And then, of course, there's COVID, which began in late 2019. Now, I want to make sure that everybody knows what it is we mean when we say a variant. The word is used so much, but I suspect that some people know exactly what it is and some people don't. So just a little bit of virology here. A virus is a particle, and the particle infects cells. And so this stage of binding to the cell is the first stage of infection. The virus must bind to the cell in order to make its way into the cell. And so what we're seeing up here in the upper right is a cartoon figure of a viral particle binding to the receptor on a human cell. The receptor is called ACE2. That's a molecule which is part of the normal cell, but the virus has the capability to specifically bind to that protein. Now, when viruses replicate themselves, which they do billions of times every day when a person is infected, the mechanisms, the biochemical mechanisms that the virus uses are not perfect. And the virus will make mistakes in replicating itself. Those mistakes can be called mutations. And many times the mutations affect the virus adversely, and the mutated virus won't grow, and that in that case the mutation dies out. But in other cases, the mutation may actually improve the function of the virus, and in that case, the mutated version of the virus may emerge as the main version of the virus. So the variants are new strains of the virus that have accumulated a number of mutants. We generally think in terms of recognized variant as having at least 10 mutations compared to the original SARS-CoV-2. Now, in the lower panel, you can see the red area is a depiction of the spike protein. That's one of the proteins of the virus, and that's the protein that binds to the cells. And so it's very sensitive to mutations that can affect the binding, either decreasing it or increasing it. And the variants have specific mutations in that spike protein and in some of the other proteins of the virus. So that's what we're talking about when we talk about a variant. And the variants can have changes in their properties so that they can spread more rapidly in some cases. They might produce more serious illness. They might be resistant to antiviral treatments. They might escape from the ability of diagnostic tests to see them, and they might escape from a vaccine. So the variants are of a great deal of concern. Very early on in the outbreak, we thought that there were not going to be a lot of variants because of our understanding at that time of the nature of the virus. And I would say that the virology community has been somewhat surprised that variants have definitely been something that we have to deal with COVID. Now, this chart shows a number of the prominent variants, so-called variants of concern, that have emerged. And we're not going to go over this in detail. I just want you to see that there have been several of them. And the most recent, and the one that we're really concerned about tonight, is the so-called Delta variant. This variant emerged originally in India. It has about between 10 and 15 mutations in that spike protein. And we've seen that it has greatly increased transmission. And I'll come back to that. Let me go on to the next slide. Now, this slide shows how the different variants have changed in their relative proportions over time since May. And what we're looking at here is this pale color, the pale beige color, indicates the alpha variant. You probably remember that from a few months ago. That was a variant that emerged in the United Kingdom and then came to the US and spread fairly rapidly and got to the point where it was accounting for more than 50% of SARS-CoV-2 in the US. But starting in May, it was replaced. You can see that its height became less and less. And the height of this new variant, which is the Delta variant, the darker beige, began to increase, and it increased very dramatically to the point where it now accounts for more than 90% of the SARS-CoV-2 in the United States. And similar events have occurred in many countries throughout the world. One of the things that's really different about Delta is that it's occurred with this rapidity and the similar pattern throughout the world, whereas in the past, the different variants have moved at different paces in different parts of the world. Now, here are some of the things we know about the Delta variant to date. One is that it's nearly twice as contagious as previous variants. Now, you know that we thought of COVID as a quite contagious illness right from the start, but now it's become more contagious, and it's right up there with some of the most contagious illnesses that we know of. It's considered to be about comparable to varicella or chickenpox in its degree of contagiousness, quite a bit more contagious than typical influenza. It may be that the data, thinking is still outstanding on this, is still out about whether it's causing more severe illness or not, but it may be. A lot of clinicians have the impression that the Delta variant is causing more severe illness. We see transmission among unvaccinated people, but we're also seeing some breakthroughs in vaccinated people, and we'll talk quite a bit more about that. Fortunately, most of those breakthroughs are mild cases or even asymptomatic, but we've also recognized that people who are having breakthrough infections, in other words, people who are fully vaccinated, but then get exposed and do become infected, and they can have large amounts of virus coming out in their secretions. So we think they can potentially transmit the virus, even if they're not having symptoms themselves. Now, let's shift gears for a minute and review the COVID vaccines, which have been such an important development. Really, it's been miraculous that a number of different vaccines have emerged in a year or less. Now, some people take that as a reason for being suspicious of the vaccine. But if you go a little bit deeper, these vaccines became available because there was a body of research stretching back close to 20 years, developing these vaccines for other applications, for things like the original SARS, for Ebola, and so forth. So this was a technology that was being developed over the years, and just as a reason why it is so important for us to be supporting scientific research, because it can really pay tremendous dividends. And that this COVID is an example where we were able to develop COVID vaccines with unprecedented speed. Now, we have two main classes of vaccines that have been licensed by the FDA. I'm sure everybody knows. The major class are the mRNA or messenger RNA vaccines. These are the Pfizer and the Moderna vaccines. They're given in a 2-dose series. And the original understanding was that they were about 95% effective, just marvelously effective in preventing COVID. We also have what's called an adenovirus vaccine. This makes use of a known virus. That virus, the adenovirus, is crippled but modified in such a way that it can receive bits of other viruses' nucleic acids. So SARS-CoV-2 RNA is put into this adenovirus, into the crippled adenovirus, and that's used as the vaccine. It's also quite effective, possibly not quite as effective as the mRNA vaccines, but still the early analysis showed that it was almost as effective in preventing severe infection, which is, of course, the most important priority. So both of these classes of vaccines were highly effective against the original virus. The Pfizer vaccine has been licensed for use down to age 12 and above, and the Moderna and Johnson & Johnson vaccines are licensed for people 18 years of age and over. And the real world experience has been very, very positive in terms of safety and efficacy. Now, when we talk about vaccine efficacy, we really have to be aware of certain nuances in the definition, because this has become very important in our current understanding of or analysis of the vaccines. Now, the first way of thinking about the vaccine is its efficacy against infection. In other words, is it preventing people from becoming infected with the virus, regardless of whether they're having symptoms or not? Now, you can only determine this in the context of a study where you're checking people on a regular basis to see if they had and became infected, even if they have no symptoms. Now, we also have the efficacy against symptomatic infection. This means the subgroup of everybody who has an infection, the subgroup who actually have symptoms along with their infection. Because we know that sometimes people can be infected with a virus but have no symptoms at all. So now we're talking about the efficacy against symptomatic infection. And then finally, we're talking about the efficacy against severe symptomatic infection. Now, each of these parameters may be different, and typically the efficacy against infection is somewhat lower than the efficacy against symptomatic infection, which tends to be lower than the efficacy against severe symptomatic infection. And it's the ideal vaccine, the absolute perfect vaccine, would be 100% effective at preventing infection. If it did that, it would block transmission, and it would also prevent people from becoming sick. But in a case of a severe disease like COVID, we would actually be satisfied if what the vaccine did was to prevent severe infection. If a vaccinated person knew that they wouldn't become severely ill, they might develop a mild illness, but they wouldn't become severely ill, that would be sufficient. So keep that in mind. Now, there are several issues facing us with the COVID vaccines that we have. One that I'll talk briefly about is the effectiveness in people whose immune systems are not normal. Of course, from the start, we were concerned that there might be some people in the population, people who maybe have congenital conditions that affect their immune system, or people getting cancer chemotherapy, or people with autoimmune diseases like lupus, where the therapy is to suppress their immune system, that some of these people would not respond properly even to a very good vaccine. We also have the issue now about whether the vaccine is effective against variants. And we have the issue that we always anticipated, how long would the protection from the vaccine last after the vaccine is given? So let's talk about each of these three issues. Now, the effect of immunosuppression first. Here's a little slide with some data, and we're looking at 4 different conditions, and we're looking at the effectiveness in various studies of the vaccine for people with that condition. And to be perfect, to have a perfect response to the vaccine, they would be up at the top at 100%. We know normal people were at 95 to 100%. And you can see here that people with cancer often were not at 100%. Many of them were quite a bit lower. People on dialysis actually did pretty well, but people who had organ transplants and whose immune system was being suppressed so they wouldn't reject the organ, they have not done so well. Many of them were not fully protected. And then people on various immunosuppressive therapies like steroid therapy are variable, but some not fully suppressed. So this figure, the data shown here, is really concerning that people with immune dysfunction or immune suppression might not be fully protected by the vaccine. And so, as you know, just a few days ago, the FDA amended what's called the emergency use authorization. That's a special kind of emergency approval that the FDA can give in a public health emergency to allow a product to be used. And the emergency use authorization specifies 2 doses of the Pfizer or Moderna vaccine and 1 dose of the Johnson & Johnson vaccine. But now the way they've modified it is to allow a 3rd dose for immunocompromised individuals or immunosuppressed individuals at least 1 month after their final dose of their original series, either the 2 doses of Pfizer or Moderna or the 1 dose of Johnson & Johnson. So this is directed, in the words of the FDA, at solid organ transplant recipients or those with an equivalent level of immunocompromise. And the interpretation of this from the CDC, which is responsible for implementation, is to include people under active treatment for cancer, people who are recipients of CAR T-cell or stem cell transplants, people with primary or congenital immunodeficiency, people with advanced or untreated HIV, people getting treated with high doses of prednisone, or people on other immunosuppressive drugs, including the biologics that are used for conditions like rheumatoid arthritis and lupus and so forth. So it's a pretty broad category. And I think the FDA and CDC are basically going to be pretty permissive. And if you have any sort of real immunosuppressive condition, it's going to be permitted for you, and more than permitted, advisable for you to get a 3rd dose of the vaccine or a 2nd dose if you got the Johnson & Johnson. But this so far applies only to the Pfizer and Moderna vaccines. There's not enough data yet to extend it to the Johnson & Johnson. And it is recommended that the people getting this 3rd dose should try, when possible, to get the same vaccine that they got their first 2 doses of. But they also have wording to say that if you can't do that, and if you have to get the other mRNA vaccine, to go ahead and do that. So this is, I think, a step forward. A number of countries, including Israel, had already taken the step before the United States. So we've now joined at least 10 other countries to make this recommendation. I think it's important. Now, what about the effectiveness against variants? This is something that we're very, very concerned about. Is it possible that a variant is going to emerge that is no longer protected by the vaccine that we're using right now? And there have been a lot of laboratory studies of this, and I'm just going to summarize this briefly for you. But here, going up towards the top is bad, being low down is good, meaning that your immune response to the variant is the same as to the parent strain of the virus. And what you're going to see here is for the Delta variant, most of the circles are relatively low, meaning that the protection is pretty good. The bottom line is that the Delta variant produces there is a response from the standard vaccines that's almost as good, not quite, but almost as good as the response against the original virus. And for some of the others, for example, the Beta variant, it's not as good as that. So Delta is not the worst of the variants in terms of escaping from the vaccine. That's where we are right now. Now, let's also talk briefly about duration of immunity. The vaccines became available in January. It's now August. So some of us are 7 months out from our immunization, and we're wondering, are we still protected? Here is some data that just came out this past week from the Mayo Clinic, and they're following people over time, and they're asking about the effectiveness against infection and and effectiveness against hospitalization. Remember, these are the two concepts of different types of effectiveness. And you can see that now they're starting to see a decline in the effectiveness of the vaccines against infection. That's regardless of whether people are having symptoms or not. And so they've gotten to the point where the Moderna vaccine has 76% effectiveness and the Pfizer 42% effectiveness. But what's more important is what's shown on the lower panel, and that's the effectiveness against hospitalization. Here, we're also seeing some decline, but not so much. So the Moderna is still at 81%, Pfizer at 75%. In Israel, somewhat similar figures with the Pfizer vaccine, which is the main one that's been used, is evident there too, that there is definitely decreasing effectiveness against infection. In other words, there are breakthrough cases in vaccinated people who are getting infected, but they're not necessarily having any symptoms. The effectiveness against severe infection is still, thank God, holding up quite well in Israel and in the United States, but we are seeing some decline. And the concern is that when you combine the effects of variants and of time, are we going to get to a point where we need a booster for everybody? And there, the jury is still out. We are seeing the decreasing levels of antibodies over time. We know that antibodies induced by the vaccine may have, so far, mostly mild, reduced efficacy against variants, but protection against severe infection continues to be seen. The data really in the United States, in my mind, do not show yet that we need a routine booster. And this is a very, very big step when we take it, because it's going to mean probably not one booster, but ongoing boosters every 6 months or a year or whatever it turns out to be. And so we should not take that step until we really are convinced that we need it. There is some evidence on the other side that the vaccine does show some promise for producing long-term protection. And so we really have to wait and see about this. Okay, I want to say a little bit about COVID in children. It may be the case that Delta is producing more infections in children. Many people have that impression, and possibly more severe infections in children. Now, up until now, we've had the idea that COVID in children is generally pretty mild, and that is still true. But there are severe cases. From the beginning of the outbreak, we've seen some cases in the hospital of children, and they usually have what we call comorbidities or other conditions that render them more vulnerable to severe COVID. And those are shown here, some of the comorbidities that we see. And I'll remind you that children 12 and over now can be vaccinated. Now, there's also a condition that you've probably heard about. A lot of the early descriptions of this were actually in New York, of something called multisystem inflammatory syndrome in children, or abbreviated MISC. Now, what is this? This is a condition that I'd say doctors don't fully understand, where about 4 weeks after a case of COVID, and it can be a mild case or a severe case, even an asymptomatic case, but about 4 weeks later, the child becomes very sick with a rash, fever, often abdominal pain, vomiting and diarrhea, sometimes some cognitive dysfunction, where they may not know where they are and so forth, and most importantly, low blood pressure. These children have to be admitted to the hospital. In fact, they usually have to be treated in an ICU, and they are very sick. They can die. Most of them, fortunately, pull through, and actually many of them make a rapid recovery, but it's a very severe condition. And most of the children who get MISC are normal children without other comorbidities. Now, I don't want people to panic. Fortunately, this is not common, but it is something that's out there. Now, I just want to share with you some of my own personal experiences, because I am a pediatric infectious disease specialist, and we have started seeing an increase in cases in the St. Louis area. And in fact, we have more children hospitalized right now than at any time in the pandemic, which is a little surprising because that's not true right now for adult patients. But these are the patients that I've seen in the past week. a 12-year-old with sickle cell disease requiring ICU care, a 16-year-old with morbid obesity requiring ICU care, not out of the woods yet, a 10-year-old with Down syndrome in the ICU, a 6-year-old with MISC in the ICU, not out of the woods yet, a 17-year-old admitted to the hospital today with morbid obesity admitted directly to the ICU, a 1-day-old born to a mother with COVID-19. Fortunately, the 1-day-old baby not very sick. But I think you can get a sense from this of a few things. One, that it's becoming more common, that most of the children have a comorbidity, but there are many different conditions out there that a number of children have that may render them more susceptible to COVID. So we can't be dismissive of COVID in children. There can be very severe manifestations when this infection occurs in children. Now, we could spend the whole session on schools. I just want to say a few things briefly, but we can certainly get into this more in the questions. These are CDC recommendations on the whole. I agree with them. They recommend strongly return to in-person learning. They strongly encourage vaccination of anybody in the school, staff, teachers, students who's eligible for vaccine. The CDC has come out very strongly for universal masking indoors in schools, regardless of vaccination status, applies to children and staff members. They say, if possible, maintain at least 3 feet between students within classrooms, but they say that if the school can't do that, if they can't reach that standard, that's not a reason to close the school. They say, go ahead. And then they have a whole set of other, what they call layered precautions, additional precautions that can be undertaken, and just which ones they are leaving up to individual localities to make decisions about, partly based on how much COVID they're seeing. But they're talking about testing, about ventilation, about hand washing, about respiratory etiquette, or making sure if you sneeze, you do it so that you contain the sneeze or the cough, staying home when sick and getting tested, contact tracing, quarantine and isolation, cleaning and disinfection. Now, I don't know if Rabbi Greenblatt is still on the call, but yes, Rabbi Greenblatt has been very associated with a large day school in St. Louis called Torah Prep. And I've had the honor of advising Torah Prep over the past year. And it's been very inspirational to me that the staff at Torah Prep was all in terms of trying to maintain school activity and take whatever precautions were needed. And the school opened right at the beginning of the year and moved ahead. The school never had to close for any extended period of time. The children got education. Now, this was not an accident. The staff was working very hard, doing all kinds of things, screening everybody on a daily basis, tracking down any infections that occurred, using masks, using spacing, improving ventilation, all kinds of measures. And we talk very frequently through the year about this and that having to do with how to keep things going. And it worked. We were able to keep the school going for the entire year. We had some cases in the faculty, and these were cases mostly that occurred that were acquired out of the school setting. There were a few instances of transmission among the teachers, possibly within the school. And so that's something that led us to be very, very happy when the vaccine became available. And pretty much all of the teachers have now been vaccinated. And we'll be starting up again before too long, God be willing, and we'll try again. So I think this is a success story, and really it should be, and I know there have been similar experiences in New York as well. It can be done. I think potentially we face larger challenges this year than in the past because of Delta. Delta may be having more of an impact in children, and it may be spreading more. And we're also possibly going into the school year at a time when we're having a surge, and a surge caused by Delta. So I think we need to be cautious. We need to go into this with our eyes open. We do have the tool of vaccination. We should use it as much as possible. Make sure that all the staff, all of the teachers, any children who are 12 and over can be vaccinated are vaccinated. That sets the ground, a very positive groundwork for additional precautions, and then go from there. I am a proponent of masking. I think it's a fairly simple and important measure. It can be effective, at least while we're in a period of significant transmission. Now, just a month or 6 weeks ago, we were talking about reducing precautions. Things were looking very, very good. And God be willing, we'll get to that point again as we get over this Delta surge. And then there may be a time to start lessening some of the precautions, but that's not where we are right now. I think now we're at a time for very significant precautions. Let me close with the last slide. Just a few thoughts about what we all can do to protect ourselves. And I'm just an unashamed proponent of vaccination. I think this is a gift to us and we should use it. Get vaccinated. And if you're immunosuppressed, take advantage of the third dose and get that third dose. Do wear masks in public indoor spaces. If you don't know all the people who are there right now, there's a good chance that somebody infected may be there. You may have been vaccinated, but we know you can break through. Most of the time, it'll be mild or asymptomatic, but there are small percentages of vaccinated people who get sick. Also, it appears that if you become infected, even without symptoms, you may transmit it to others that you care about. You may have a household contact who's high risk, so keep this in mind. And I strongly advise wearing masks in indoor public spaces. If it's a small gathering of people you know and you trust their behaviors and they've been vaccinated, I don't think you need to wear the masks. But other than that, I think masks should be worn indoors. Outdoors, as we've come to understand, is a much safer environment than indoors. But with Delta, once again, I think we have to be a little bit careful, and intense crowding outdoors potentially, I think, this is just my own speculation, but might not be completely free from transmission. So I think it's a good idea to avoid crowds, whether you're outdoors or indoors. And we can talk more about travel in the Q&A, but I think we should be cautious about traveling, at least right now. So that's the formal remarks that I have, and now I'll be very happy to take any questions. So thank you very much for your attention.
Thank you. Rachel?
Okay, well, Dad, thank you so much. That was great, as always. And thank you also to Rabbi Greenblatt and to Jacob and to all of those listening in the audience. Whether you're a member of the Fifth Avenue Synagogue community or listening in from across the country, as I know some of you are, we're so glad that you've joined us tonight. We hope that you'll continue to join us for our Sunday programs, which cover a wide variety of topics and feature outstanding speakers. So tonight, I'm thrilled, of course, to have my dad with us. He's the Ruth Siteman Professor of Pediatrics and Professor of Medicine and Molecular Microbiology at WashU School of Medicine. Also the past chief of the divisions of Pediatric Infectious Disease and Pediatric Laboratory Medicine. I was hoping that at this point, we would be looking at COVID in the rearview mirror, reflecting on an unanticipated episode in global public health, and doing so from the comfortable vantage point of our prior lives. But obviously that's not the case. And almost 18 months after the beginning of the pandemic's impact in the United States, we're once again feeling the ground shifting under our feet. So, while certainly unsettling, we do approach this new phase armed with some knowledge from our experience and some tools in our arsenal, most importantly, the vaccines, of course, and some increased knowledge about treatment as well. We're very grateful, Dad, that you took the time tonight to give us this important update. I do think there's a lot of confusion out there about what exactly we need to do to keep ourselves and our community safe. The vaccine has certainly created a sense of security for many people, but they're now presented with new information about the transmissibility of the illness to others, breakthroughs in the vaccine, and other questions. I know that people do have a lot of questions. Some have already been sent to me by email, and I encourage you to send any others through the chat or Q&A function. I'll ask as many as time allows before we wrap up for davening at 7:35. Since we do have the benefit of having a speaker who does both research and clinical care, you can ask broad questions or are those more specific to certain circumstances?
Rachel,
From there, I'll ask the first
can I jump in here? Rachel,
Yes.
can I just
Sure.
jump in with one question and
Yes,
jump
please.
ahead of the line? What about people who have had COVID and have antibodies? Is your father recommending that they also get vaccinated? And if not, how long do those antibodies last?
Right, Rabbi, thanks for the question. And there is immunity after a person has had COVID. But the interesting thing is that if you have had COVID, and then get the vaccine, you get a great increase in the antibody level, and probably also importantly, the breadth of the antibody response, its ability to neutralize or deal with the other variants expands. So you get a wonderful response based on having had COVID, which we're not recommending, but having had COVID and then getting the vaccine. So yes, there is some protection for sure after having COVID, but you have better protection, probably more durable protection and broader protection if you get the vaccine as well. And that's why it is strongly recommended to get the vaccine after COVID. But yes, a person who's had COVID. Yeah, I'm sorry, go ahead, Rach.
No, I was just going to ask, is there a sense of how long the antibodies last?
Yeah, I don't think we really know the answer to that question yet. Just like the antibodies from the vaccine, they do decline over time. So I just don't think we have a good sense for when they really decline below protective levels.
Mm-hmm. Okay, so we have a question submitted by Dr. Oscar Weg from our synagogue community related to travel. And he's asked, he has a son, a daughter-in-law, and 2 grandchildren, ages 3.5 and 2 months old, who live in Seattle. And they're planning a vacation trip for Sukkot in September from Seattle, Washington to the tri-state area. How do you rate the risks, and what's your sense of advisability of a trip like that?
Yeah, now there's no cut and dry answer to this very important question. It does have to do with how much you need to do the travel, what your tolerance is for risk, and so forth. But let me say a few things about it. First, of course, we have the situation here where there are some children who can't be vaccinated. And unless you know that they had COVID, they are likely to be susceptible. They could become infected. Now, we do know that if they become infected, it's likely that their infection will be mild. There is a small chance that they could have a severe infection, but the great likelihood is that their infection would be mild. I'm going to assume that the parents have been vaccinated. That's very important. I would not travel if I were not vaccinated, but vaccinated, you have some protection. Now, I have made several airline trips in the last several months, and I've been impressed that there are opportunities to become infected that I couldn't avoid during that travel. In other words, it's not entirely safe. There's been a lot of publicity about how safe the planes are when they're in the air, and I think that's true. There is a lot of air exchange when the planes are in the air, and so the air is moving. It's not your worst enemy, but you often don't know who's sitting next to you. Not everybody is good about wearing their masks. You could wind up with a highly contagious person very close to you. The process of boarding the plane doesn't necessarily have the same ventilation as being up in the air. The process of deboarding the plane, likewise. Your travel to get a rental car may involve unintended contact with people. On one of my trips, I was in a very crowded terminal. There was literally no place to sit down, and I had to be there for more than an hour, just full of people. So I think that you do have to go into this with your eyes open and recognize that you may not be able to fully control your exposure. But if you are vaccinated, then you have a fair level of protection, and that may carry you through. And so I think these are all the things that have to be balanced. I would not say do not travel, but I would go into it with your eyes open, make sure you have a very good mask, and distance yourself as much as possible from other people, and do those things. And the issue of the children is a particularly sensitive issue. I would try to have the children wear masks if they can. Now, you said a 1-year-old and a 3-year-old. The pediatricians generally say the children 2 and over can wear masks. It would be worth a try for the 3-year-old. The 3-year-old may or may not be able to. The 1-year-old probably can't, and you just have to face that.
So Dad, speaking about masks, we have a question from Mr. Stanley Slater, and he's asked, is the primary purpose of the mask to stop the wearer from contracting COVID, or is the mask primarily to stop the wearer from spreading COVID to others?
Yes, good question. And it really does both. It certainly protects, blocks the transmission. That's quite effective. And it also has a nice effect on blocking the acquisition of infection. Now there, the quality of the mask comes into play. If you wear a very simple single-ply cloth mask, then some of the virus in the air is going to get around that mask and you will be exposed. One thing that's been recommended is to wear a paper surgical mask underneath and then cover that with a cloth mask. That helps protect you. Wearing a 3-ply cloth mask is also good. And then the N95 so-called respirators, the KN95, the KF94, these are all higher level masks that are particularly valuable for increasing your own protection. Now, early on in the pandemic, it was discouraged. People were discouraged from using those because they were on short supply and we needed them for medical personnel. But that's been relieved. And so you can get those now. And I do recommend those for if you're in any sort of risky situation, especially something like travel. I recommend trying to get an N95 mask. You have to be careful because there are a lot of counterfeits on the market, but if you shop carefully, you can find them. And I think that's a good thing to increase your protection. Any mask will also protect quite a bit, will protect against transmission. So it's both altruistic and self-protective.
So Dad, in New York, they've created lots of opportunities for outdoor dining, which people are taking advantage of, but they have returned to indoor dining. And I was just curious, sort of in the same vein of the masking, do you think that either or both of these are safe at this time? If you're indoors, should you have a mask on while you're not eating? And what are your thoughts about restaurants?
Well, the indoor environment is not entirely safe in that if there's a person who's infected, let's say one person who's infected in the indoor environment, and that person is there over time, and in the case of a restaurant, they're not masked because they're eating, then with each breath, they're going to be putting virus into the air. And over time, that virus will accumulate in the air, the so-called infectious aerosol. Now, if the ventilation is great, that aerosol will blow out and disperse. But if the ventilation is not great, it will accumulate. And if you're there in the indoor restaurant eating, you're also not masked and you are potentially exposed. So I personally would not eat in an indoor restaurant unless there was a requirement for vaccination. Now, that's another matter. If everybody there has been vaccinated, then you've changed the equation, and I think it potentially is safe. But I would not go into a restaurant that does not require vaccination for everybody, both workers and diners.
Okay, thank you.
Outdoor is different because outdoors, the ventilation is so much better, the aerosol disperses, and the likelihood of transmission is much less. But you do, even outdoors, you want to make sure that there's some spacing between the tables.
Right. So similarly, this is really a New York question, but Broadway is supposed to open again this fall. Yeah. And I think they are now deciding to require, they'll be within the proof of vaccination settings. But what are your thoughts on something like going to a theater at this point? Same as restaurants?
Yes, quite similar. I would only go if a vaccination requirement is in place and if there's some consideration for masking. Because if there are unvaccinated people in there, then there's potential for transmission. So I think this is a great experiment. I think it's worth trying. I applaud the theaters for doing it, as long as they're getting good advice and doing it in a prudent way. And I think, I think we should be cautious as consumers and go slow and see what happens, but hopefully it's going to be possible. But again, it depends. It also depends on how much virus is in the community. If we're in a period of major surge, that's really going to be a challenge. If we're at a time that like we were at just about 6 short weeks ago, where the virus seemed to be declining, the risk would be much less.
So someone submitted a question. They said, you seem to downplay the danger of, quote, non-serious or asymptomatic disease.
Mhm.
But they asked, what about long haulers or the possibility that even these types of so-called mild infections might contribute to more severe morbidity in the future?
Yes, it's a very good question. And if I transmitted that impression, I want to change it, because we just don't know what the long-term consequences of mild infection or even asymptomatic infection are. We know this is a virus that can affect many parts of the body, and it is possible that things will emerge as we move forward that we don't know about right now. So there could be some consequences. In the short run, these infections, the asymptomatic infections, seem to pass without a lot of consequences, but that may be a very incomplete view. And so-called long COVID, I think it's possible that it may occur after mild or asymptomatic infections. And so that is another good consideration, important consideration.
So a question was submitted by Jenny Merkin-Brenner. That's actually one a lot of people are asking, both that I know, both parents and grandparents. And I'm going to read her question. She said, if you had to compare the precautions we should take today to previous levels of precautions in the initial lockdown last summer, last fall, what should the vaccinated, healthy individual do? And this is really the question I want to know the answer to. What about vaccinated parents with unvaccinated children?
Yes, well, I think it's probably not feasible to wear masks in the house. So I would say be sure you're vaccinated, and then make sure your child is in as safe a situation as possible. Hopefully the school is taking the precautions that it needs to take, and then go forward. If the child gets sick, consult with the pediatrician, get the child tested if necessary. But this is where the vaccine is so important. I think if people have been vaccinated, for the most part, they're going to come through that situation okay.
One person has asked a specific question saying, if you have an open wound or in the healing phase, would you be immunocompromised?
No, that would not be the kind of immunocompromise that's being talked about for the additional dose.
Okay. And then another New York City question where everyone is riding in elevators and sharing hallways. Should we wear masks in those common areas, even if vaccinated?
I would say yes. The CDC has come out strongly saying that people should wear masks in public indoor spaces, and I endorse that recommendation. You don't know who's on that elevator and what their infection status is, and if you want to protect yourself, wear the mask. And we have to recognize now that even if we've been vaccinated, we could be asymptomatically infected without our knowledge. So by wearing the mask, if by any chance we're infected, we'll be helping other people.
Here's another question. We have relatives planning to fly cross country to visit us over Thanksgiving. Said relatives have been vaccinated, but I'm still concerned about having them stay with us immediately after arriving. Is this an irrational concern?
No, it's definitely not irrational. It's something to think about. Of course, there is the possibility. But if they've been vaccinated, again, we're dealing with relatively low probabilities. And if you've been vaccinated, we're talking about them being vaccinated, you being vaccinated. There are 2 levels of protection there. One other thing to keep in mind is the possibility of doing testing. You can now, testing is widely available. You can even get antigen tests in the drugstore without a prescription. And in a situation like that, you could test them as soon as they arrive. And if they're negative, the tests are probably pretty good at identifying who's contagious. And so if you get a negative test, they are probably okay at that moment. Now, because they've traveled, there's the possibility that they acquired infection during travel. If you're really concerned, you could repeat the test again 3 to 5 days later. So that's something to keep in mind if you're very worried.
Okay, here's a question about vaccines, Dad. It says, what about people who have allergic reactions? Should they take the vaccine as well? And is there any risk to taking the vaccine?
Yeah. So this is something that you have to consult with your own doctor about. True allergic reactions to the vaccine have been very, very uncommon. It's true that many people, 10, 15, 20% of people have some kind of local reaction or mild constitutional reaction to the vaccine. You can have some symptoms for sure, but the great majority of those are not true allergy. And if you have a reaction like that to the first dose, it doesn't necessarily predict whether you're going to have a reaction to the second dose. If, though, you really think that you had an allergic reaction, you should be in touch with your physician. And if the physician agrees, then you might want to forego the vaccine. But I would be hesitant to do that because I think true allergic reactions to the vaccine are really unusual. And it's really nice to have the vaccine under your belt.
One listener has asked, when do you think there will be a study that will identify whether recurrent infections are increasing as a result of loss of immunity of the vaccine or due to the nature of the variant itself?
Yeah, those studies are ongoing, and we'll see information emerge, in the subsequent days, weeks, months about that under intensive study. One thing I didn't say, and people may know this, but it's quite likely that the vaccines will be approved for children down to age 6 or possibly even lower over the course of this year. And if the studies really show that the vaccines are safe and effective in young children, then that will be a very important step forward, particularly with regard to schools, and we'll want to make sure that kids get vaccinated.
Speaking of the vaccine for children, Dad, could you comment on the FDA requiring increased numbers of enrollees and follow-up time to approve EUA for vaccine for children under 12? It seems the risk of delay is likely higher than the risk of vaccine side effects, and delay may result in increased morbidity and mortality in kids.
Yeah, well, this is just something that they have to weigh. The more people in the trial, the more assurance there is that you've detected adverse reactions, but you do pay a price with slowing things down. So I think they will just be trying to find the golden path in between that gives them enough children to be confident that the vaccine is safe and effective and doesn't delay its use too much.
Okay. We just have time for one or two more before we have to stop for davening. But here's one. From your understanding, is a person who had COVID and then gets vaccinated, is the impact of long COVID reduced?
Yes, it's a good question. And I'm sorry, I don't know the answer.
Okay. And then somebody has asked if you would recommend the N95 mask for a subway commute.
Well, I guess it depends on how crowded the subway is. If it's a deserted subway car, not necessarily, but if it's at all crowded, yes. And what I would suggest is getting hold of some N95 masks and trying them out if you can wear them and you don't find them uncomfortable, because it is a little harder to breathe through the N95. But if you can tolerate them, use them because they are more effective at protecting you than the standard masks.
Okay, and just one very quick follow-up on the theater discussion. This person said, you say that in the theater there could be an unvaccinated person who could spread the disease, but can't vaccinated people spread the disease too?
Yes, I mean, we're having to reassess everything as we grapple with the Delta variant. Not too many weeks ago, we were thinking that vaccinated people probably were usually protected and not going to be shedding the virus. But now we recognize that, based on partly waning immunity and partly the variants, that there may be some shedding. We think that the period of transmission for vaccinated people, the period during which they can transmit, is probably shorter than people with standard infection. But this is a concern, and I think we're just going to have to see what happens as we move forward with trying to hold some public events. Ideally that are limited to vaccinated people, and see whether there's transmission or not.
Okay,
I think it's worth trying.
Yeah. Dad, there are actually many more questions, but we do have to stop for Dad.
Rachel, if you want to go on a couple more minutes, I'm going to break for Mincha. But I want to thank you and Dr. Storch and Rabbi Greenblatt for a great program. And Rabbi Babbage is out tonight. That's why he's not with us. But Rachel, go ahead. I see you have a lot of questions. That way people can participate. So go on, okay?
Okay. So
Thanks, Jacob.
Rachel, it's Rabbi Greenblatt again. Can I ask you a question?
please.
I'm getting this asked by members of my shul, Dr. Storch. People that are over 60 or 65 who are vaccinated, attending shul on a daily basis when there are people who are not vaccinated in attendance. Should the people not come to shul or just mask up and, you know, and attend with the mask? And does the crowd factor make a difference in that situation?
Well, you know, this of course is a complex question with ethical dimensions, but I think I'll take a crack at it, and you can correct me. I think that it's okay for the vaccinated people to continue to come, but I personally think they should wear masks. And I think that it's unfortunate that there are unvaccinated people, and I think they pose mainly a risk to themselves, but to some extent a risk to other people. I would try hard to get them vaccinated to the extent that you can. Obviously, it's not, they would have been vaccinated if you had that ability to get them vaccinated. But
there'll always be children that are not vaccinated, children under 12. So even if every adult is vaccinated, they're going to bring their children. So there's not going to be a possibility to have everyone vaccinated. So at that point, you're saying if anybody is vaccinated, wear a mask and try to
yes,
that way.
I think so, and try to maintain the best ventilation that you can have and some distancing. And the children, you know, the parents with children should try to keep their children from circulating too much. It may be difficult, but they should try. So I think there are some common sense considerations.
Thank you.
Dad, one of the listeners has asked, does an mRNA vaccinated individual who becomes infected with the Delta variant after vaccination, even if it's asymptomatic, develop better immunity than an mRNA vaccinated individual who's not infected?
Yeah, I haven't seen the answer to that, but I would guess yes, because the getting the disease or getting infected is a tremendous stimulus to the immune system. And so it's likely that there would be a very broad and strong response in that person. The person had an mRNA vaccine and then became infected. They would probably have a very strong immune response to that experience.
Okay. One listener has asked if you could mention the Lambda variant, which may be vaccine resistant.
Okay. The Lambda variant is another variant that emerged in Peru, and it does seem to be somewhat better at evading the vaccine immunity than the other variants that we've been dealing with. And so it needs to be watched very closely. So far, there has not been much spread of Lambda within the United States. So that's the good news, but it needs to be watched, as do, you know, we have to watch very carefully for the emergence of other variants. But the thing that's been so dramatic about Delta and really unexpected is that a virus could just march across the country, really march across the world the way Delta did, and establish itself as the predominant virus in just a period of limited number of weeks. That's very unusual.
Somebody has asked, is there a booster currently available that's been tweaked to specifically combat the Delta variant?
Yeah, the researchers and the vaccine companies are working on that. They're working on a couple of things. They're working on Delta-specific vaccines, but they're also working on vaccines that would have the ability to stimulate very broad immunity that would cover a number of different viruses. They're playing around with the idea of combination viruses, just like a flu vaccine has 3 or 4 different strains of influenza in it. They might have a second generation SARS COVID vaccine that would have several different strains. So yes, more to come on that.
Okay. One of our listeners has asked, would you recommend or suggest that it's safe to take a weekend trip to Bermuda for 2 vaccinated adults if they have a 9-month-old baby staying with them?
Well, I think there's, I think there is some risk entailed, probably pretty small for the 2 vaccinated adults, but the child certainly would be at some risk of becoming infected. So that's the thing that you have to deal with and decide, whether you want to take that chance. The chance that the child is going to get seriously sick is small. It's not zero, but it's small. You can do everything you can to try to protect the child during the travel. But as I mentioned in my own experiences, I found myself in situations that I couldn't control on each trip that worried me about the possibility for transmission. And I was very thankful that I had been vaccinated. I think that's what carried me through. But if I were susceptible, I think I could have gotten infected.
One of our listeners has asked, what is the proportion of hospitalized patients in Israel who are fully vaccinated? And do we have any data about the age and health conditions of those people?
Yeah, that's a good question. I don't have as much information as I would like about that. My understanding is that even though there's some disturbing figures coming out of Israel that I think and the studies have high credibility, showing decreased vaccine efficacy, they're still showing quite good efficacy against disease that is seriously symptomatic that would require hospitalization. So I think the percentage is probably still fairly small, but I don't have any specific figures.
Okay. Let me just make sure I'm not missing anybody. I think I got to most of these. Okay. Okay, Dad, I think I've gotten to most of
Okay.
questions. I just want to thank Rabbi Greenblatt and you again for spending this hour with us. It was another extremely helpful update on COVID, and we're so lucky to have you as a resource. You're always welcome to join us, but I hope that another update like this will not be necessary. So thank you for spending the hour with us, to both of you, and Dad for sharing so much information and your insights. It's an honor to have you, and so appreciated.
It's been my privilege and pleasure.
Thank you very much, Rachel, for inviting me. Much appreciated.
Yes.
Good night. Thank you.
Thank you, Rabbi Greenblatt, for that wonderful introduction. I really appreciate it.
Thanks so much, Rabbi, and thank you, Jacob.
Good night.
Good night.